work here. So Dr. Saigal and Dr. Rajgopal has made my job easier here. There will be multiple repetitions. I hope bear with me on that. So moving on to the patient details. So our patient was a 38-year-old male, ethanol-related decompensated cirrhotic liver disease with ascites, jaundice, and hepatic encephalopathy. MELD score was 20, and he was blood group O positive. He was evaluated for liver transplantation. His wife was found to be a suitable liver donor. She was O positive, 21-year-old female, BMI of 21, and the right lobe graft 608 grams, and the expected GRW was 0.75. Anatomy was straightforward with a single artery, single portal vein, and one V5 and V8. So he underwent right lobe LDLT. The GRW was 0.70. HTK solution was used to flush the graft. V5 and V8 reconstructed on 8 mm PTFE with a common outflow. So cold ischemia time was 133 minutes and the warm ischemia time was 27 minutes. He received 6 units of PRBC transfusions. So he was reasonably stable through the surgery with moderate requirement of inotropes. Urine output was good, but the lactate clearance was poor. The end lactate at the end of surgery was 15. Intraoperative Dopplers were normal. So in view of inotropic requirement and the high lactate, he was shifted on ventilator into the ICU. So post-op day 0, so he was worsening with increased inotropic support, hypotension. He was sensorium was poor, and urine output was dipping with 40 ml per hour. Peak lactate went up to 17, and INR serially increased to 8.84, and the peak enzymes AST of 2052 and the ALT of 1984. Dr. Vijay, your comments at this point. What do you think, and what would be your approach to?
So this patient is going in towards PNF. So once we diagnose PNF and once we make sure that there is no vascular etiology for the cause of the PNF, then we have to plan a retransplant first, and then we have to, if possible, do an emergent graft explant, and we have to change the disrupted physiology, starting from we have to support the synthetic function of the liver. We have to maintain sugars. Then we have to change the INR based on the point of care test. Then we have to also supplement the metabolic function of liver, by removing ammonia and urea, so that we avoid any cerebral edema. We maintain sodium on the higher side to avoid cerebral edema. Then we also we do start CRRT to actually maintain the acid-base status as such, and coagulopathy.
Sure. At this point of time, what was the Doppler for?
Most important is we actually we have to maintain normothermia, near normothermia, so that we don't have any the adverse effects of hypothermia.
This is the POD1 of the surgery. So what was the Doppler like at this point of time?
So Doppler both
artery, portal vein, UMHV.
Yeah, intraoperative as well as the postoperative day 1 Dopplers were normal. So Dopplers were normal. Like Dr. Vijay mentioned, all the supportive measures were initiated. He was started on CRRT. So he continued to deteriorate through the day, but post CRRT, the lactate came down to 9.9. So patient, we just sent blood cultures and other, viral markers. Everything came out to be negative, and patient continued to be unconscious with worsening lactate, persistent acidosis, hypotension with high inotropic support. Liver enzymes were high, INR was high, and there was decreasing urine output with rising creatinine. So, as we discussed earlier, with this picture, we considered it as primary non-function of the graft, and decided to list him for a retransplantation under super urgent category. We had a discussion with the family, and there was no compatible, suitable donor available. So we had to wait for the deceased donor organ.
Can I just make a quick question? It's fairly unusual to have like a PNF on day 1 without a technical issue. It's also like worrying to go for another graft if you don't know why the first graft failed. So I just wanted to figure out, like, was there anything else you were thinking?
So we did, whatever we had in our hand was imaging. Doppler was normal. He was very unstable.
The
So
CTA?
we shifted to the CT.
Okay.
and he was on high inotropic supports. Probably, yes, we could have considered CT on the night of the transplant when lactate was going up. Unfortunately, we missed that window, We went on high inotropic support to be shifted to the CT. So other than that, we couldn't find anything else that could be, any correctable cause. So he was deteriorating fast, so we considered it as primary non-function. And post listing him for super urgent listing, we had an A positive organ, in-house organ, they were A positive patient, brain dead declaration was there. So Dr. Chandan, your thoughts? Suspected PNF?
Super urgent listing, A group, I think it's still, we should proceed. We can do the ABO-incompatible.
Yeah. So we did look at the A1 versus A2 debate. So unfortunately, it was again A1. So so our thoughts was to go ahead and look at the other data in terms of, we already discussed the importance of baseline anti-A titers that would make our job easier in kind of desensitization protocols. So we went back and looked at his preoperative samples that were collected before the right lobe transplant. So the baseline preoperative anti-A titers were 1:128. And the titers at that point after the right lobe transplant were 1:64, probably secondary to the bleeding and the blood transfusions he had received during the initial procedure. So it was 1:64. So this was encouraging. And we also looked at the baseline CD19 count, it was 21%. So with all this data, we decided to go ahead and consider this organ, as there was no other organ available and patient was deteriorating. So Dr. Dheeraj, what's your policy in Andhra Pradesh? Or do you have the organ allocation policy that across the blood group deceased donor organs are allocated in your state? Or?
So this definitely needs super urgent listing and needs a transplant. But then the policies are there in US and UK. They have well-defined criteria for PNF and listing criteria. Enzymes more than 5,000, high INR, high lactates, and acidosis. This is a criteria for them. But for in India, I'm not aware, and we have different practices across state.
Yeah. So
I don't think we have any cross-listing criteria in our state as of now for super urgent.
Sorry.
I don't think we have any cross-listing criteria as of now for super urgent where we can cross-list for a patient with different blood group in super urgent. Yeah.
No, so it's not. We don't even. Nowhere, I don't think in India anywhere it's a policy. Even in our state, this is not the policy. But then we had discussions with the liver advisory committee. I think Dr. Sonal is here. He was heading the liver advisory committee that time. So we had discussions with them and explained them the situation. And this organ was from in-house. It was from our own hospital. So this was not affecting the rota. So considering it as one-off situation, they gave us permission to go ahead with the transplant. So we decided for going ahead with ABO-incompatible deceased donor liver transplantation. Now coming to the desensitization protocol, what would be your approach at this point? What would be the desensitization protocol?
This is a case of primary non-function and then retransplant and then ABO-incompatible DDLT. These are all very intriguous factors. Okay, and we don't have enough time to desensitize now because on one end the patient is rapidly deteriorating. So what we do is that we can give rituximab on day 0, and before that we can start plasmapheresis, because with plasmapheresis rituximab can get drained off. So first do plasmapheresis and then give the shot of rituximab.
Agree, sir. This was we thought on the similar lines. So we went ahead with double volume plasma exchange and achieved target anti-A titers of 1:8 prior to the transplantation. So if we look at the various protocols that's been practiced across the world in emergency ABO-incompatible transplants, including both LDLTs and DDLTs. So the commonest thing you see across the various teams is rituximab, whether it is 48 hours prior to the transplant or on day 0 post-liver transplant, and perioperative plasmapheresis to bring down the anti-A titers, and post-operative triple immunosuppression. So considering basiliximab and IVIG, this varies from team to team. Few teams have considered basiliximab and IVIG, but it is not uniform across various teams, even in emergency situations. Dr. Mathur, your thoughts on splenectomy in this scenario?
I mean, your patient is like high pressure, is unstable. I probably would just like go roll the dice with rituximab, IVIG, and triple immunosuppression and see where we go.
This is exactly how we thought actually. He was on high inotropes and high inotropic support. He was unstable. He had large splenorenal collaterals. So in view of this, we just went ahead with deceased donor retransplantation with caval replacement technique. So the right lobe graft appeared pale. It was fatty and shrunken. The hepatic artery, portal vein and hepatic venous anastomosis were patent. But the V5 reconstructed on the PTFE graft was thrombosed. Apart from that, rest of things were normal. The histopathology of this right lobe graft showed multifocal confluent and submassive necrosis with around 60% microvesicular and macrovesicular fatty change. The C4D staining for this was negative. So post-operatively, there was no significant reperfusion syndrome intraoperatively. Patient was improving, the inotropic support were coming down, and urine output was better, the lactate was decreasing. And post-reperfusion, we gave him a dose of 3.5 mg of bortezomib. And after the surgery, 6 hours post-surgery, we gave him rituximab of 300 mg. I think we have discussed enough about the role of bortezomib in the previous discussion. So basically, this approach was influenced by a publication by Chen Li et al., wherein they had a quick preparation for ABO-incompatible transplants. This was primarily for living donor transplants, but we followed this protocol wherein it consisted of bortezomib of 3.5 mg injection to deplete the plasma cells and the plasma exchange to achieve isoagglutinin titers of less than 1:64 prior to transplantation, followed by rituximab of 375 mg per meter square on post-operative day 1. So this was the basis for our desensitization protocol what we followed.
Yeah, but then if I can ask, like the donor parameters, the BMI was 21 for this donor, the first transplant that happened. And also the GRW was 0.7. Yes. So yeah, GRW was slightly less and the donor looked lean. I don't know about the graft, but the biopsy shows small, the 60% of microsteatosis and small for size syndrome. So like, although patient was behaving like PNF, should waiting for some more time would have helped us if this was small for size syndrome or IRI?
Yeah, small for size syndrome on day, basically, see, to begin with, the graft never appeared to be functioning from the intraoperative period, actually, increasing inotropes, increasing INR, moving on for even renal dysfunction, poor sensorium, all these things were there, and probably, yes, if there was no organ offer, it could have given us a time to assess, and see where it goes, but then with this critical picture there, and with the organ available, we actually didn't get time to, give it that much time and assess what about the organ functions. But regarding the steatotic change, what we have seen is like what we see in acute liver failures. The liver dysfunctions, they usually lead to severe steatosis. Even we have seen this in even other severe allograft dysfunction as well.
I'll just make a comment on that. Microvascular steatosis is not uncommon when you have like some liver injury. It usually doesn't have any impact on the liver function. There's a lot of DDLTs that have, the donors have a bunch of microvascular steatosis. I've used up to like 95% microvascular steatosis grafts to find. It's not an indication of function at all.
Agree. But anyway, this was the finding was seen in the histopathology post removal of the graft. So post retransplantation, first 2 days were good, the graft functions were good, and day 3, patient became conscious and oriented. Inotropes were tapered off, he was hemodynamically stable, he was extubated, and urine output was good. So day 3, his titers jumped to 1:16. So we did a plasma exchange in that, and day 4, even on plasma exchange, titers jumped to 1:64. So we repeated a dose of bortezomib of 3 mg on day 4. So all well until now, and then post-op day 5, there is derangement in liver function test with bilirubin jumping up to 13, AST of 139 and ALT of 146. The titers were 1:128. Dr. Chandan, any comments at this point?
I think we should continue plex.
Sorry?
Reduce the titers to less than 1:16. We should continue.
Yeah, so this was an issue, with liver dysfunction, titers going up to 1:128. So we suspected it to be an AMR, although we didn't do a biopsy. We immediately switched from plasma exchange to column immunoabsorption. Glycosorb column immunoabsorption was used. And we also started him on IVIG at a dose of 0.4 gram per kg for 3 days. And pulse steroids were also given. Dr. Mathur, is there any role of splenectomy as a salvage at this point?
I think it would still be like a little bit challenging. You could try like just a splenic artery embolization and see what that does, rather than going for a surgical.
No, you could have done splenectomy during the transplant, no? Retransplant.
During the transplant.
Yeah,
So during the transplant, like Dr. Mathur mentioned, he was very unstable hemodynamically and there was a lot of splenorenal collaterals. We thought that might add on to the morbidity and
No, during the second transplant, maybe splenectomy could have been done at that time in trop.
during the retransplant.
During the
during the
retransplant.
retransplant also he was very much unstable, sir. So we did not consider at that time. And now at this point, so the role of splenectomy did cross our minds, but then we went back and repeated the CD19 counts, but it was 0.26% on post-operative day 6. So the target CD19 counts were achieved, and we waited for next 2 days wherein, luckily for us the titers came down and the graft functions improved. So titers slowly, gradually reduced to 1:32 and the liver function test gradually settled. On post-operative day 9, we had to repeat a plasma exchange, and by day 14 the titers were 1:4 and graft functions had settled. So the patient was discharged on post-operative day 16. Regarding the splenectomy as a salvage, I have an experience in my past institution where we had done an A2 to O transplant without desensitization protocols, but then unfortunately the patient did develop rebound titers post-operatively, and he also had liver dysfunction of the graft, so did not respond to column adsorptions and all that. So on post-operative day 10, we had to go in and do an emergency splenectomy, post which his graft functions settled. So there is a role for splenectomy as a rescue therapy, provided our CD19 counts are not, we hadn't achieved target CD19 counts, or if still despite of CD19 counts of less than 1% if the graft functions are not settling. But luckily for us the graft functions settled, so we did not consider that. So this is the timeline of various events of management in this patient. So this 20 months post-op, he is doing well with good graft functions. The recent LFTs are normal with a bilirubin of 0.8 and enzymes AST of 24 and ALT of 28. So it's a brief review of literature on the emergency ABO-incompatible deceased donor transplants. Quickly, I'll just finish quickly. So ABO deceased donor transplants, the Western world has reported this from since 1990. 2.6% of adult liver transplants done in US were ABO incompatible emergency transplants, and but the outcomes were not up to the mark that time. Although the pediatric transplants were okay, the graft functions were comparable between the compatible and incompatible transplants. When it came to adults, the graft survival was poor in ABO incompatible transplants. In the emergency category I'm speaking about. So the reason behind this was most of the teams did not follow a uniform protocol, and mostly they didn't use rituximab or splenectomy as a part of their protocol. So the teams which just depended upon the plasmapheresis pre-operatively and post-operatively to achieve the anti-antibody titers. But then they had the rebound of titers post-operatively. So the first successful publication on emergency ABO deceased donor transplants were from Hanto et al. And group in 2003. So they had pre-transplantation and post-transplantation plasma exchange and splenectomy and quadruple immunosuppression as their protocols. So the 1 and 5 year patient survival and graft survival rates were 71% and 61%. So they were comparable to the ABO identical groups. There was no incidence of AMRs in this set of patients. So this, again, there was an editorial by Mayo Clinic in Transplantation Journal where they assessed the data published by the successful ABO DDLTs, and they also concluded that this should be considered when the blood group compatible donors are not available in critically ill patients with fulminant hepatic failure. This was another publication from Newcastle. I think Dr. Srinivas Reddy is author of this paper, where they did this in 2007 with a desensitization protocol of perioperative plasma exchanges, and they also used rituximab, splenectomy, IVIG, and basiliximab. With this, I think this patient also did well. This was in 2007, and recently in 2022, the Scandinavian Journal of Gastroenterology, they published 20 cases of ABO incompatible deceased donor transplants using rituximab and basiliximab as the desensitization protocol with perioperative plasma exchanges. They did not consider splenectomy. Most of the centers, splenectomy is off the protocol now. And even they had very good outcomes with 1 and 5 year patient in graft survival rates of 85 and 78%. So, with this experience from the Western literature on ABO-incompatible DDLTs, multiple Indian centers are coming up with emergency ABO-incompatible LDLTs in pulmonary acute liver failure settings. This is one publication from Dr. Reddy sir and team, and Dr. Vivek's team has published a case series of 3 cases wherein they did an emergency ABO LDLTs, one following ALF and other 2 following, one following PNF also after LDLT. So there's a lot of literature coming up on ABO-incompatible LDLTs in emergency settings. And there's enough literature in the Western world regarding the ABO-incompatible DDLTs in the emergency settings for this thing. I couldn't find any published literature in the Indian centers on ABO-incompatible DDLTs. So I think it's a time where ABO-incompatible DDLTs can be considered with a reduced risk of antibody-mediated rejection. So the perioperative double volume plasma exchanges, rituximab with or without splenectomy, and triple immunosuppression reduces the risk of AMR. ABO-incompatible DDLTs can be an option in critically ill acute liver failure patients. So is it the time, can we reconsider our policy for organ allocation in super urgent listing? That needs to be discussed, and that's a food for thought to look at our organ allocation policy in ABO-incompatible in acute liver failure settings. Thank you.
I would say Herculean effort and miraculous escape.
Sorry.
It was a Herculean effort and a miraculous escape of this patient.
Thank you.
You made the right decision on day 1.